Hello everyone. Remdesivir has been in the news in the last few days, with the FDA in the US approving it for emergency use in COVID-19. Remdesivir inhibits coronaviruses in vitro, including the SARS-CoV-2. Besides, it has been shown to have antiviral effects and clinical effects in SARS and MERS infections, and was studied for the treatment of Ebola virus disease as well. Remdesivir was also trialed on a compassionate basis among 61 patients with COVID-19 infection, but this was an uncontrolled study and not much could be concluded from this uncontrolled study. Now, how does Remdesivir work? The SARS-CoV-2 attaches itself to the ACE2 receptor on the cell membrane and thus gains entry into the cell. Once it enters the cell, it releases its RNA, and this RNA literally hijacks the host cell. And it forces the mitochondria of the host cell, which are the factories of protein synthesis, to replicate itself. So several copies of RNA are formed. This occurs with the help of an enzyme called RNA-dependent RNA polymerase enzyme. So essentially, the virus forces the host mitochondria to replicate its RNA. And these RNA is formed in large numbers, and they form a large number of viruses which exit the cell and go on to infect other cells as well. Now, where does Remdesivir come into the picture, and how does it inhibit the virus? As you know, the RNA is comprised of adenine, guanine, cytosine, and uracil. Remdesivir is a congener of adenine, and it bears a lot of resemblance to adenine. So when you give it IV, it enters the cell and it takes over the position of adenine within the RNA, given that it's very similar to adenine. So instead of adenine, you have remdesivir incorporated into the viral RNA. This results in a configurational change in the viral RNA and causes inhibition of replication of the RNA. Thus, because of its similarity to adenine, remdesivir occupies the place of adenine within the RNA and prevents its replication. So that's how it works. Now, how does remdesivir fare among patients with COVID-19 infection? There has been 2 large studies the results of which we know, one of which has been published in The Lancet, and the other we just have preliminary information on. So let's look at the Chinese study first. This was a study conducted in China, where it all started. It was a double-blind, placebo-controlled, randomized controlled study involving 10 hospitals in Wuhan. So what did they do? They randomized patients in a 2-to-1 ratio. For every 2 patients who received remdesivir, 1 patient would get the placebo. The inclusion criteria were patients who presented within the first 12 days of symptom onset. They had evidence of pneumonia on either the chest X-ray or the CT scan. The oxygen saturation was 94% or less on room air, or they had a PF ratio of 300 millimeters of mercury or less. They excluded patients who had evidence of liver dysfunction, as in a raised AST and ALT, because remdesivir is known to worsen liver function. They also excluded patients who had renal impairment, patients who were on CRRT, or patients who were on hemodialysis. Other treatment modalities were permitted according to the judgment of the treating physician. Remdesivir was administered in a dose of 200 milligrams on day 1, followed by 100 milligrams from day 2 to day 10. So they screened 237 patients, out of whom 158 were allocated to receive Remdesivir, while 78 patients received the placebo injection. What did they find? The primary endpoint was clinical improvement in 28 days. Clinical improvement was predefined and was based on an ordinal scale. So with Remdesivir, clinical improvement occurred in 21 days, which was a median time period of clinical improvement, compared to 23 days in the placebo arm. So this difference was not statistically significant. So the time taken for clinical improvement in the first 28 days of treatment was not different between Remdesivir and placebo. The hazard ratio was 1.23 with a confidence interval of 0.87 to 1.75, which essentially meant a non-significant level of effect. They also looked at secondary endpoints, which included all-cause mortality at day 28. This was not different between Remdesivir and placebo. All-cause mortality at day 28 was 14% with Remdesivir and 13% with placebo. They also subdivided patients into those who received early treatment, early as in within the first 10 days. And when they looked at the effect of early treatment on the all-cause mortality, this was numerically less with Remdesivir compared to placebo, 11% versus 15%, although it was not statistically significant. What was the result of late treatment after 10 days? Paradoxically, Remdesivir seemed to worsen mortality in patients who received treatment later than 10 days, with the mortality being 14% versus 10%. Again, this was not statistically significant. They also looked at time to clinical improvement among patients who received the treatment within the first 10 days. And among patients who received treatment within the first 10 days, the time to clinical improvement was lower with Remdesivir compared to placebo, although this again was not statistically significant. There was no difference in the need for invasive mechanical ventilation, nor in the duration of oxygen therapy, nor in the hospital length of stay, nor in the number of patients with nosocomial infections between the two groups. The investigators also looked at viral clearance at different points of time from the upper and the lower respiratory tract, and this also was not different between the Remdesivir treated and the placebo treated arms. So essentially this study showed no difference in the time to clinical improvement with Remdesivir compared to placebo. However, among patients who were treated within the first 10 days, Remdesivir seemed to help, although this was not statistically significant. What were the limitations of this study? The study was actually powered in such a way so that they could detect a difference of 6 days between the two groups to detect a change in clinical improvement of 6 days, assuming the time for clinical improvement with placebo would be 21 days. But unfortunately, the study couldn't reach the projected power of 453 patients because by the time the study got through the halfway stage, the outbreak had died down in Wuhan and enrollment slackened at that point of time. So the study was terminated on March 12th with a power that was only 58% compared to the 80% that they had aimed for. Treatment was initiated later with enrollment up to 14 days. They couldn't enroll patients early because the outbreak was a very large scale one to begin with, and patients usually presented late, and they couldn't get sufficient number of patients who came early to enroll them early. Combination with other drugs and other modalities involving the use of corticosteroids, the use of interferon alpha, the use of lopinavir, ritonavir, and the use of convalescent plasma, all of this could have resulted in treatment bias, although they were equally distributed, roughly equally distributed between the two treatment arms. So that's the study from China, which was published in The Lancet just a few days ago. It's against this background that you have the ACCT trial, which was a large study conducted by the National Institute of Allergy and Infectious Diseases in the US under the National Institute of Health. And they announced the results of their very large study, much larger than the Wuhan study. This study used a adaptive design in a randomized controlled fashion. An adaptive design is used to change randomization probabilities in such a way that it favors the arm that shows promise during the course of the trial. So they trialed out this adaptive design among these patients, and they enrolled patients between the 21st of February to the 19th of April, including 1,052 patients involving multiple centers across multiple countries, including the US, including France, UK, Denmark, and so on. So it was a truly multinational, multi-centric study. What were the endpoints that they looked at? The primary endpoint was a median time to clinical recovery. Recovery was discharge from hospital or recovery to a predefined level. And the time to recovery was significantly less with the use of Remdesivir. The median time to recovery was 11 days in the Remdesivir arm versus 15 days in the placebo arm. This was statistically significant with a p-value of 0.001. They also looked at the 28-day mortality. The 28-day mortality was also lower with Remdesivir, although not statistically significant. The mortality was 8% with Remdesivir compared to 11.6% in the placebo arm. So this study, which was only the preliminary results, were announced by the director of the National Institute of Allergy and Infectious Diseases, Anthony Fauci. He came up with these results. The full results have not been published. It will probably take a few more days for the full results to be published. We need to go through that in detail, but based on the information that we have so far, this looks like a promising therapy. Of all the different drugs that have been trialed in COVID-19 infection so far, Remdesivir appears to hold the most promise, and we would certainly await the full results of this study. In the meantime, as I mentioned, the FDA has granted emergency approval for its use among COVID-19 patients. Thus, from all the evidence available so far, Remdesivir certainly appears to hold some promise. The treatment of COVID-19 may be multimodal, not just involving a single drug. Like in the Chinese study, they used multiple modalities at the same time. And the choice of modalities would depend on the individual clinical circumstances. That's it, folks. Until next time, goodbye.